Hydration and IV Therapy Part 4, Introduction to Nursing Concepts, Martha Olson from Iowa Lakes Community College. Many different types of IV access devices are available. The ones you will be putting in the lab are called peripheral catheters. They range in size from 16 to 24. 16 is the large one that I call the garden hose. 24 is saved for pediatrics, very small, fragile veins that we have to use. We will be talking about the midline catheters. The PICC lines are inserted by nurses that have special training. They go in the basilic vein, very close to the heart. Lots of sterile technique involved with that, but they're left in for a longer period of time, like a month or greater. They're great for TPN, for patients that maybe have osteomyelitis and need long-term IV therapy. And then our other ones I will explain as you can see the pictures as we get going. The peripheral vascular device then, as you can see, they come in different colors. The pink one on the bottom is a 20, and I know that because you kind of just know and are able to say a 20 is in because they're pink. It's very universal in size. They're short peripheral catheters. They go in the superficial veins in the hands and forearm. They can stay in for up to 3 days, and then they must be removed, replaced in a new site to avoid getting an infection to that area. The green is an 18 gauge, the 20 is pink. Complaints of tingling or pins and needles feeling to the extremity or numbness would indicate that you have damaged or punctured a nerve and would need to remove that. The needle extends beyond the catheter sheath. When you insert it, a stylet goes in with it. We take that out once the venipuncture is complete because we don't want to go down through the bottom of that vein and cause it to bleed and have problems. As we look at the little scalp vein devices, usually those are used in pediatrics if we have no other access but to go in through the scalp. And then the over the needle is the most common. It's with the catheter, and then the stylet. It's anywhere from a half to 2 inches in length for each of those. This is what we call the midline catheter. It's about 6 to 8 inches long, and it goes into the antecubital fossa. It's used for therapy from 1 to 4 weeks. It's placed between the antecubital and the head of the clavicle. It's advanced then into the large vessel just below the axilla where there's good hemodilution. And again, it's left in for up to 4 weeks. We do not want to give anything into a midline catheter such as chemo or TPN through this type of IV. With this type, as soon as it's inserted, we do an x-ray to confirm placement or per policy of the facility. It's recommended for placement in the basilic, the cephalic, or the median cubital veins, and it's a great insertion site 1 finger breadth below or 3 finger breadths above the bend of the arm. The basilic vein is the preferred because it's larger and follows more of a straight path for the catheter to advance. And we do not, again, want to use this site if they've had a mastectomy, dialysis, any type of shunt or graft in that arm. The one that nurses with special training put in then is what we call the PICC, or peripherally inserted central catheter. I had a nursing student a couple of years ago. Her little boy was very sick, and he said, "Mom, I got a pickle line." So he thought it was like a pickle. The length of the PICC line is 40 to 65 centimeters. The basilic vein is the preferred site. It's confirmed with an x-ray, usually a chest x-ray, to make sure that we have not gone in too far. We flush it with a special protocol. The flushing is always a 10 milliliter syringe, and the rationale for that is the PSI, or the pressure. It's a small catheter size, and we don't want to put too much pressure. It's saline, then the additive, or whatever we need to give them, the saline, and then it's flushed with usually 2 to 3 cc's of heparin flush. So your peripheral line, the one you insert, is only flushed with saline. Typically, the PICC line is flushed with heparin. We need to teach patients to perform normal activities of daily living, but avoid excessive physical activity to that arm. So like holding a grandchild or carrying groceries with the arm with the PICC line would not be recommended. It's a very sterile technique for insertion. The PICC line care and maintenance follows hospital protocol. It's sterile gloves, sterile policy. Have the patient turn. They put a mask on so the germs from their breath are not contaminating your IV or PICC site. The first 24 hours after insertion, we put a gauze dressing in place over the insertion site, and then we cover it with a transparent dressing. It's changed then every 7 days or as needed. The length of the catheter is measured, and I will show in class a video about how they insert a PICC line. Not that you will do it for a long time, but with special training, but it does give you a greater appreciation of how far that catheter goes up, how they measure it, and how they are using very sterile technique to ensure that we do not get an infection. With the peripheral catheter, the one you will insert, you can usually easily see because it's so superficial when you have an infection or a phlebitis. With this one, it's deep in the vein, very close to the heart, and the only way you would know that you have caused or the PICC line is infected is they're going to have a white cell count that's elevated. They are going to feel malaise. They may be running a fever, have more of a systemic, and that's a more serious because it's gotten to the point of systemic instead of just a localized infection. The injection cap is changed to the PICC line every 7 days. Its intention is for long-term use. Somebody with osteomyelitis might get antibiotics for 6 weeks, and a PICC line would be appropriate for them, because remember, with the peripheral line that we start, that has to be changed every 3 days. So this one would cause less pain by having less frequent IV sticks. The non-tunneled percutaneous central catheter then is often called a central line. You can see the 3 ports coming out of that. This is inserted into the subclavian vein in the upper chest or jugular neck during a surgical procedure. It's 15 to 20 centimeters in length. The tip resides just above or superior to the vena cava. Its placement is confirmed again by a chest x-ray, and it's a sterile dressing over that. The advantage of this central line is you can put 3 things in. If this is a patient in your intensive care unit or critical care, you can hang blood into the brown port. You can have IV fluids hanging and going into the white port, and the blue port maybe has a heparin drip or a dopamine drip or something in that. So that's the real advantage of this. Each one of them is flushed again with a 10 cc syringe, so you don't put too much pressure to it. And the central line per protocol is typically flushed with a saline and then a heparin flush to that. Your tunneled central catheter then, a portion of the catheter lying in a subcutaneous tunnel separates the points. It's a single, triple, or double lumen type that is used. It's surgically inserted and also surgically removed. The inside is usually 20 to 30 centimeters long, and the names you'll hear, a patient will say, I have a Groshong, I have a Hickman, I have a Boviac type of catheter. These are confirmed with chest x-ray, and after the site is healed, sometimes you don't even have to put a dressing over the top of this type of long-term catheter that's been inserted. The implantable port then is underneath the skin. Most of my patients that have these are cancer, oncology patients that need a lot of blood draws, that need chemo. So in surgery, we put this implanted port in. It's under the upper chest, typically on the left side, and you can feel it when you palpate. It's flushed after each use and at least once a month. So if somebody has chemo, go through the radiation, they're doing very, very well, and they aren't getting anything, they may simply come into the same-day surgery once a month. The nurse flushes it with heparin to keep it patent, and they go home and life is good. With this, it's under the skin, so when you implant the Huber needle into this type of port, you will have to pierce through the skin. It can be a little tender at first for them, but usually that skin gets kind of toughened up, so if they've had it a while, when you insert that needle, they may not even tell you that they feel any discomfort with that. You would have a standing order to flush it, again in same-day surgery. Some of the patients will use maybe a little Emla cream over the top of that as it's very tender so that it's not as uncomfortable. This is the Huber needle that we would use in that implanted port. It's a 19 gauge. It looks like a number 7 or an L because of the shape to go into that implanted port. We hold the side of each of the wing tips that you see, and it sticks above the port. So when I insert this into the port, it pushes until you feel it release, and then you know you're in. You flush to make sure that it's in, and if it flushes hard, you're probably not in or you're in too far. Then you use 2x2s and clear opsite sterile technique to cover this Huber needle to keep it in place as you're infusing meds or doing whatever you need to do with your patient with the implanted port. The dialysis catheter we don't do a lot with. That is put in for the patient that needs dialysis. With the dialysis catheter, your biggest thing is not to start an IV in the arm where that catheter is. You can feel and hear the bruit and the pulse through that, the thrill and the bruit. With these dialysis catheters, they're put in and they have to heal for a period of time before we can use them in dialysis, but once they have them, they work very well. We do not use, again, that arm for any IVs or try to avoid any blood pressures to that dialysis site. Your patient with the type of IV access, make sure you follow the protocol of your facility to know what size of syringe you use, what type of needle, how often it's flushed, if you use saline and then heparin, so that you're following the protocol of that facility. For these types of IV access devices, my last thing to say is that nurses can draw blood off. So if your patient has an implanted port, when they come into the hospital, to avoid many IV sticks or blood draws, the lab will call up and tell you, we need to draw blood off of so-and-so's port. So we stop the IV solution. I go in with a clean syringe, pull back 5 of blood, discard that. Then I pull back and obtain blood in the second syringe and hand it to the lab personnel, who will then go and run it. I flush it then per protocol, and life is good.